Hello from me too. I would like to welcome all the panelists and all the participants to this nice and well-organized webinar from Riz and Saran Duraya. I'm in the delightful position to introduce a couple of our speakers today. Of course, everybody knows Dr. Joe De Giovanni. Dr. De Giovanni was born in Malta, finished school in medical school in Malta, and as he had great ambitions, he got a scholarship and came in Birmingham in 1975. He worked hard in medical training and cardiology, but he was more fascinated by pediatric cardiology. And in order to fulfill his dream for pediatric cardiology, he had to come to Brompton Hospital in order to do the training. For family reasons, mostly, he decided to go back to Birmingham again, and in 1983, he was appointed as an consultant in Birmingham Children's Hospital, and later on he became also a consultant in Queen Elizabeth Hospital. Of course, he never forgot his own native land. And he managed with another colleague from London to organize a pediatric cardiology training back to Malta and to establish the pediatric cardiology department there and the program there. For that reason, he got the Order of Merit from the Malta for the training, and in that way, he also became and he got the position of professorship in University and Medical School of Malta. Always open in sharing his enormous experience and knowledge, he involved in charity work all over the world, from Asia to Africa and Middle East. Dr. De Giovanni is not only a true Europeist, as he is the scientific secretary of APC for 5 years now, and this year especially he is going to give the lecture for Hausdorff's lecture in APC. But he is also a real British, as he is council member and treasurer for the BCCA. I think that I will stop here because most of us, we know what he has achieved in his time, and we are delightful that he gave us his thoughts, his ideas, and that I am personally delighted that I had the chance to work with you, Joe. Please, you are going to give a talk on the evolution of pediatric cardiology, pediatric cardiac catheterization. Joe, it's you now.
Thank you. Let me just try and put this on. Right. Good afternoon. Thank you very much for asking me to participate in this landmark move for Leicester, and thank you for the very nice comments. Only a few years ago, Leicester was very much at risk, and that was due to a flawed exercise of so-called safe and sustainable. It was not safe and it was not sustainable. So I'm glad that Leicester not only survived, but is actually thriving. And we also have a very good link with Leicester. Before Chen went there, we had a very good relationship with Monty Goldberg and Pete Hubner, who were both adult cardiologists, but who were very enthusiastic about congenital heart disease. And we had we saw each other more as friendly neighbors rather than as rivals. And Now, there are obviously a number of consultants in Leicester who have also passed through Birmingham. So I hope that link will continue. I think that things have moved on, and I think although there were comments about the imaging taking over, there are other values of cardiac catheterization, but it didn't happen overnight. So the first measurement of pressure was carried out in a horse. The arterial pressure was measured in a horse by a so-called Reverend Hales. He just put a copper pipe down the carotid and saw how high the whole thing went. How he saw it, I don't know, because obviously it wasn't visible, but I suspect he probably moved it up and down to just check how high it went. Later on, Claude Bernard, he put a glass cannula in the carotid and jugular, so he could actually see the blood. But he also put in a thermometer in the ventricles, because there was a theory that the ventricles, right and left, had different temperatures, which is obviously not correct. But the real breakthrough was in Germany, from Werner Forssmann, who was in Berlin, and he came up with the idea of catheterizing patients, having read the information from Claude Bernard, but he obviously did not have any materials, so he used a urinary catheter in his left cubital vein and fed it into the right atrium just to make sure it's safe, and then took an X-ray to confirm it. He was obviously castigated for it. He was suspended and then dismissed, and that's sometimes life. Sometimes you have to do what you have to do. And unfortunately, he left cardiology and went into urology. However, when it came to actually patient catheterization, the people who really drove this were André Conant, who was from Paris but moved to Columbus University in New York, and Dickerson Richardson. The angiography started really in the 50s, and it was mainly for valves. And selective angiography only came about by chance when Mason Soanes from Ohio was doing an angiogram in the aorta. The catheter slipped into the right coronary artery without people noticing, and they did a massive injection. And the first thing he said is, "We've killed the patient." As it happened, the patient actually survived, and there were no real issues like VF or anything like that. And that gave him the idea of starting selective angiography. And he was the first one really to design catheters specifically for selective angiography of the coronary arteries. His design was superseded by the Judkins, because they were a lot easier to use. And with Soanes, many a time you had to do a brachial cut down, whereas with the Judkins, it could be done through a Seldinger technique. So in terms of intervention, the first one was essentially done by a radiologist, Charles Dotter, who recanalized the blocked iliac artery. This was just by chance. He was doing a renal angiogram and discovered that the iliac was blocked before, but not after. So that was a chance move, but it was also peripheral rather than cardiac. The first real cardiac intervention was the balloon atrial septostomy by Bill Rashkind in 1966 for transposition of the great arteries. And then the major thing started with coronary angioplasty and obviously valve replacement. So the three people at the top got the Nobel Prize in 1956 for medicine. When Forssmann was contacted by the Nobel Prize committee, he said, why me? I haven't done cardiology for years. But obviously what he did was really special. At the bottom, we see Bill Rashkind and Mason Soanes. You may not be able to see the bottom right so much, but that's Sham Singh, who was my predecessor at Birmingham Children's Hospital, and he was the first person to do a balloon atrial septostomy in the United Kingdom. If we go through the slides here, the top right, you can see in the light blue jacket is Chuck Mullins. Everyone knows Chuck. not only because he's very experienced, likes to share his experience, but he also came up with the idea of the Mullins sheath, which gave a different concept to a catheter. And obviously, without the sheaths these days, we do no or very little intervention. The second slide, the one in the orange, is Terry King. He's the first to do ASD closure in 1977. The next two are Julio Palmas and Charles Schatz. They invented the stent. So the history about this is that Julio was at a conference in about coronary angioplasty, which was being given by Andreas Grunzig, who was the god and the inventor of angioplasty. And this was in 1978, which is 1 year after he had started the process, the procedures. And Andreas Grunzig admitted that although the angioplasty works, there's a high recurrence rate, and it would be nice if there's something that can keep it open. And Julio thought, well, you know, we need to put a scaffold. And this is where the concept of the stent came. Now, there were no stents available, so he went to one of the Radio Shack stores, which are electronic places in the US, bought a bit of copper wire and some soldering, and invented a stent with diamond-shaped holes. It was obviously kind of a waste of time because copper is very soft. It's also fairly thick, and soldering has weakness. So he wanted to find something a little bit stronger, and he had some builders in his house. And one of the builders left a beading, which the Americans call a lathe, which you can see at the bottom there. And he came up with the idea, this is how I make a stent. You know, it doesn't need any soldering. It's made of steel. We can make it low profile. And that's how stents started. There are many areas of development, and they will continue, no question about that. And that includes vessel access, catheters, contrast imaging, and devices. And we'll go through some of those. So as far as vessel access is concerned, to start with, it had to be by cut down. We very, very rarely do cut down these days, but sometimes you may need to do that. To get into the pulmonary artery, we had problems with the veins, and sometimes there was. There was a technique where you could actually enter the pulmonary artery from the suprasternal notch. So essentially use a fine needle, go into the suprasternal notch, go down and backwards. So you're going to puncture the innominate vein, the aorta, and then the pulmonary artery, and you can measure your PA pressure doing it that way. Because you're catching all these organs, we used to call it a shish kebab. And I only was involved in a couple of these, and you know, being a junior person, I was quite frightened about it, but it worked. LV direct puncture does work. We don't need it so much these days, but in patients with aortic stenosis in the distant past, it was a problem, particularly before the Mullins sheath, where we could actually enter the left ventricle from the left atrium. But sometimes these days we use it for paravalvular leaks. The Celtic technique made a big difference because you know, it removed the cut down side of things, and that has advanced in many ways. And in terms of access, we can access pretty much anywhere. And particularly with ultrasound guidance, we can access pretty much any vessel that we want to. In addition to entering the vessels, we now have different sealing devices, which can go up to really very, very, very large French. You can put 2 or 3 devices sometimes, such as the ProStar or something similar, or the Perclose. The problem that sometimes we have, particularly with babies, is that we lose the pulse. Fortunately, I think because the sheets are so low profile and so good, most of the time when you lose the pulse, it's due to a clot. It's not due to a flap in the femoral artery, whereas in the past we used to have flaps and we used to have surgeons to help us out. These days, thrombolysis sorts it out. In terms of catheters and wires, to start with, they were made of latex, but this broke down in the patient. It wasn't very good, they were fragile. But when vulcanization of rubber with sulfur was invented by Goodyear, this was taken up for medical purposes, And the catheters, particularly the urinary catheters, which is what they were needed for initially, it made a lot of difference. However, something magical happened in the 1940s, and DuPont invented Teflon. They invented it really for kitchenware as a non-stick, and it has worked and is still in use. So that's absolutely fantastic. However, there is a dark side to it, and that is that there are certainly hundreds of thousands of people who have died as a result, because there's a byproduct of the of Teflon, which the company have been throwing in the rivers, and people have been poisoned. So it causes cancer, it causes teratogenicity. They've changed this material, but apparently it's still not as safe as it should be. Now, in addition to making the Teflon for the kitchenware, DuPont also produced sheets of Teflon and also tubes of Teflon. Not that they knew what they were going to be used for, but just in case people had some bright idea. And in fact, Bard, which is a manufacturer of catheters and other equipment for medicine, cottoned on to this idea of having a tube made of Teflon to have cardiac catheters. And that's exactly what they did. So they cut a piece of tubing and used it as a catheter. Obviously, there were disadvantages. First of all, the lumen is never very big unless you have a big catheter. There was no hub to it, so they had to invent a metal hub, which had a lower lock or something similar. And you had to do it by hand. So you get the tube on its own, you get the hub on its own, and you screw it together. So the catheters were never of the same length. And also they were just straight catheters with an end hole. So they had very, very limited values in them. However, and they were pretty expensive. You know, because they were expensive, and you know, in those days there was no budget for catheters and so on. People thought about the idea of recycling them. After all, when we use the frying pan with Teflon, you know, we use it many a time, and people said, well, we can re-sterilize these, and that's what they used to do. So when I started, when we used a catheter, it used to be made of Teflon. After the procedure, it used to be cleaned from the outside. Then it used to be linked to the mains water for the cleaning of the inside. And then it's very easy to dry the surface, but you can't dry the lumen. So they had to blow air through there just to dry it up. And then they would make it into a circle, put it into a paper bag, and sterilize it. We could sterilize them 40 times. So we used to have a piece of paper inside the bag with 40, and you go, you put the date whenever it's been sterilized. Obviously nowadays, if Riz asks Sally for a Justin's Right special, and as soon as she opens it, he says, "Oh no, I actually meant a multi-purpose." She wouldn't really shout at him, but if he did that in the 70s, I bet you she would, because it was a very laborious process to clean these catheters. But catheters have moved on. There are different plastic materials. They have now different shapes, diameters, balloon tip, monorail. You know, you pretty much have whatever you want to. Wires have also improved in a big way, as we know. When they started, they were just pure metal, and people just had to make a curve, but make sure that you stay within the catheter, because they were not, they did not have a soft tip. But nowadays we have a lot of safety and you know, a lot of variations, steerability, chronic total occlusion wires, and so on. And obviously the sheets have improved as well. Some are now braided, some are steerable, different sizes, you know, you name it, we are really lucky. In terms of contrast, things have improved. When we started, the contrast was really very thick, it was really like diesel, and it was very allergic and toxic. So you had to be very careful. Nowadays we have better and safer contrast media. Now, in terms of delivery, we obviously have the pump, which is electronic. You can change whatever you want to. But when we started, this was in the 70s, the pumps were made of solid metal, and they looked very much like a whale harpoon. And they used to just be driven by a high pressure, which was linked to a cylinder. So you couldn't see if there were any air bubbles, and forget about the rate of rise and this, that, and the other. There was just no sophistication at all, but it worked. The imaging has improved immensely, as we know. It started with a single plane, but then it was replaced by biplane, movable arms, and so on. And we now have also rotational. We have so many options these days, which is quite incredible. So when we started, we didn't have any cine. There was a company from Sweden called Schonander, and they used to make an angiographic system where there were about 16 plates. So if you want to do an angiogram that included an aortogram or even a coronary angiogram, you get 16 plates. So you can't see it as a movie. You then have to develop them, and then you can actually view them and so on. So it was, not a very good process, but it was the beginning. It was then replaced by cine angiography and eventually by digital. So things have moved on in a very, very big way. As far as the X-ray equipment was concerned, it was static. It was fixed to the floor. You couldn't move it at all. So the only thing that you could move was the table. And for a while, the table was just flat. You couldn't rotate it at all. So for the adults, we had like a cradle. It was like a cradle, and you had to strap the patients, and then you can rotate the cradle right and left to do RAO and LAO. But there was no option for cranial or caudal. The picture at the bottom is Roy Astley, who was a radiologist. His interest, that's Birmingham Children's, his interest was also photography. In particular, he was keen on cine photography, which was at the beginning in the 40s and 50s. And he was also very interested in cardiology and contributed a lot to it. And when he started and wanted to do imaging of children with heart problems, he realized that there was no equipment for children. He recruited a chap called Manfred Rühl, who was a prisoner of war. He was on a fighter pilot. He was a fighter pilot for the Germans, for the Luftwaffe, and he was shot down and taken as a prisoner. And when he came out, Manfred married a local girl and stayed in this country. Lovely man, very, very, very intelligent. His engineering knowledge was just beyond comprehension. And he was a very nice person to work with. And Roy Astley and Manfred built the first pediatric single plane angiographic system using 16 millimeter cine at that time. And obviously, like all the other X-ray equipment, it was static. So there was no C-arm or anything like that. But what Manfred Rühl did is he created a hammock, and with the hammock you could turn it RAO, you could turn it LAO, you could do it cranial, and you could do it caudal. Very, very simple, and it worked. How do you make it go into RAO and LAO, say 30 or 15 degrees? Very simple. It was all managed with pulleys and rope, and he put knots at certain points. So if you want RAO 30, you find the RAO 30 knot and you just put it there. It's amazing, but simple. Things have improved in terms of archiving, as we know, and we're now very much into digital and digital subtraction. So the objective of catheters is obviously several: pressure, saturation, and geography. You must think about that wherever you are within the heart. You don't need to do all of them, but some of them you might need. And then you have to think about intervention, biopsy, or other procedures. Devices have, again, improved beyond comprehension, and that includes balloons, closure devices, particularly with the Amplatzer devices. You know, we have, that really changed the scene completely. Stents, you know, again, you know, we have so much variety these days, and we're obviously now moving into percutaneous valves, but not just replacement, but the repair process. And I think that is really very, very, very exciting. I wish I was 20 years younger to actually get involved with it. So just to show you a few examples, this is a patient who had an occluded left pulmonary artery through an arterial duct, and using a CTO wire, you can actually open these up and restore flow. Stents, a few years ago, I was one of the first ones to place RPOT stents in babies with Fallot's tetralogy, and I think it works extremely well. It's a very good alternative to a BT shunt, and we never saw any fractures. We saw some instant stenosis, but not actual fractures. But in the adults with congenital heart disease, you have to be careful. And this is an adult patient with Fallot's tetralogy who was referred to me by Jane Somerville. And I did, you know, warn him and warn Jane, you must follow these up, but, you know, neither of them listened. Unfortunately, he ended up with stenosis, and Paul Clift and myself managed to reopen it and put another stent. Very important when you're doing this, that you know that you are in the lumen. So as far as the central picture is concerned, you open up a small balloon and very slowly to make sure that you're not between the struts. Obviously, sometimes we have to be a little bit innovative, and doing fenestrations for Fontan works very well, but it also depends on the surgical technique. So with TCPC, it's sometimes very difficult to puncture the conduit, the extracardiac conduit. So we designed, Chetan Mehta and myself designed this procedure of approaching the pulmonary artery from the jugular and creating a controlled shunt. ASDs very common, but you know, they are not all without problems. And this is a patient with 2 ASDs, and you can see the 2 devices there. You will notice that they are actually rubbing against each other, and the tissue between them wasn't so thick. So I was contacted, this was at the QE, so we usually do them on Friday. I was contacted on Saturday, and I was told, well, the ASDs are still there, but the devices are in the pulmonary artery. So can we do it tomorrow? And I said, yeah, that's fine, give him heparin and we'll do it tomorrow. Clearly, they were not in the pulmonary artery. If you look at the one of them, it's actually flat on the side, so that tells you you're in the aorta. The other one that's floating could be in the pulmonary artery, but as it happened, it was in the ascending aorta. So, you know, we had to remove both of them. The tissue between the 2 ASDs had broken off, and we then resized and put a device that she did absolutely fine. Erosion can happen with ASDs, and this is the only erosion I've had. Again, if you look at the chest X-ray, the device is not exactly round. There is a flat bit, which means it's rubbing against something. And if you look at the bottom right corner, you can actually see the erosion of the device through the wall of the left atrium. Fortunately, she had a limited pericardial effusion, and she had surgery successfully, so without any problems. Ducts, we obviously closed them, and the latest development has been closing ducts in preemie babies, generally using the ADO2 AS, which is designed for that, but some people have been using the Medtronic plug as well, or vascular device. But we can also keep them open as an alternative to a VT shunt. The apical approach, as I mentioned, we don't use it very often, but sometimes for paravalvular leaks in the mitral particularly, this is a very, very good technique. This is a case that I did with Ziad Hijazi in Taiwan, where there were two devices you can see on the 3D. And the important thing, which I had probably been covered, is that you put a plug device before you come out, and we do the same with transhepatic puncture. I'll pass these on because now sometimes we have to think laterally, and this is a patient with a very large coronary fistula, as you can see. She finished up with LV dysfunction and mitral regurgitation. I thought the vascular plug looked great, but there was still a lot of flow, and it eventually embolized into the pulmonary artery, but it was easy to remove. So I replaced it with a VSD device, which is a lot stronger, and it stayed there very nicely, but there was still residual flow, and we put many coils, a lot of ruby coils, but there was still flow. So we came with the idea of using Onyx, which is a liquid type of embolization device used by the radiologists, and that closed the shunt completely. I had no experience with Onyx. I know it's a very difficult material to deal with. So in that situation, you involve a colleague within radiology to help you out. Valve replacements, Cribier obviously started in 2000 and Bonhoeffer about the same time, or 2001, for the aortic and the pulmonary. And now there are numerous valves available, and they're used for all the four valves that we have. In this particular case, we have placement of a sapien in the RVOT, and another valve which is the Melody valve in the tricuspid position. However, I think the challenge, and things have moved on big time here, is the concept of valve repair. This is largely for tricuspid and for mitral in particular. Initially, this was done through the Apex, partly a hybrid procedure. And David Mirkin, who very kindly gave me a couple of slides, has been very instrumental in developing this. And they have now moved on from the hybrid to the percutaneous approach to a transseptal approach. David is a very, very clever guy from Jerusalem, and I'm very proud to have proctored him for several procedures. And you can see at the top there, these are animal studies that he did, David did, to repair mitral regurgitation in an animal. I'm not sure why it's not going forward anymore. Let me just see why it's not going forward anymore. Okay. So sometimes, we have to think laterally, and patients with tricuspid regurgitation, yes, if you can put a valve, a new valve, that's fine, but they can't all tolerate it. You may not have the ring, it may be too big. So as an alternative, you can actually put either one valve in the IVC, because a lot of the problems with tricuspid regurgitation is congestion of the gut organs. But sometimes you may have to put one in the SVC and one in the IVC. This is one in someone with ascites, very marked tricuspid regurgitation, and organomegaly, and we placed initially a self-expanding stent followed by a sapien valve. And I think it works extremely well, and certainly clinically, this patient did very, very, very well. We obviously do new things as well, and we always thought that sinus venosus, superior sinus venosus ASCs were not amenable to transcatheter closure, but this has obviously changed and it's growing. And I'm grateful to Joseph Whitcutter, who's one of our senior registrars, who is now in Michigan. The link with Leicester has been good for me. As I said, we started with Monty Goldberg and Peter Hubner, who worked very well together, not just about congenital heart disease. Me and Sham Singh were the first in Birmingham to do mitral valvuloplasty with the Inu balloon in 1985. And I remember linking up with Peter Hubner, who was also an interventionist, and we did some good work together. But I was I'm very pleased to have come across so many good people. Obviously, Chen Chen, who is with us today, and his wife Kin, remember them very fondly. It's so nice to see him. Obviously, I did some work with Abdul before he left, and also with Dimitris, but largely with the current team as we are. So I'm very grateful. I wish you good luck, and I thank you for inviting me. Obviously, things move on, and we can see that even in the aeronautics, things have moved on. Sometimes disasters happen. So long as you try to avoid them, and if it happens, you learn from them, that is the best thing, that's the best outcome that you can have. Thank you.
Thank you, Joe, for the nice talk. It was really amazing seeing all these pictures and all these interventions, and knowing that you are joining us whenever we have asked you to come here. I think that we are late. I don't know if we have to go in one or two questions, or we should move forward to the next talk. What do you think, Riz?
So I don't think there's any questions from the attendees, but Atul or Manos, if you have a question, then we have time for one.
Atul?
Yeah, no, I was, Joe, that was an excellent talk. And it's really, as Manos has said, we've always been indebted to you. You've always supported Leicester whenever we needed. I just wanted to know, what do you think, is going to be the future evolution of this specialty going forward? I mean, you've seen it right from the beginning, but going forward, what do you think is going to be the evolution of this specialty? In which area do you think we are going to make further progress? Thank you.
It is difficult. I mean, I think valve repair is going to be very important, and particularly, say, for patients with Fontan who land up with AV valve regurgitation. I think that's going to be a very important contribution. I suspect that we may also be able to do, say, Fallow's repair in the future, because we should be able to open up the RV outflow, maybe in a serial manner. And if we have VSD devices which are safe and acceptable, we may be able to do some of them. I don't think we'll be able to do all of them. I think certainly we should be able to deal with, say, hypoplast in a hybrid way, and then eventually go into a sort of Gert Hausdorff type of Fontan to do everything percutaneously. So I think these are things that will eventually happen in the future. If I wanted to upset my surgical colleague, Bill Braun, I used to tell him, one day we'll be able to do an arterial switch percutaneously. And he used to just jump up and down and think I'm completely mad. I was just simply pulling his leg. I don't think we're going to do away with the surgeons. I don't want to do away with the surgeons. I value their opinion. I value their techniques and skills, and I think we have to work together as a team. But it was good from time to time to pull his leg.
Thank you very much, Joe.